Well, I was doing it, I kept looking, I was like, why is the 15 degree angulation off of it? It's supposed to be down instead of up.
Yeah, they have a reverse Caldwell.
They have a reverse Caldwell, which is up, but then a regular Caldwell, which is just.
It should still be a Caldwell from the AP projection.
So they have the
So we're at the Nasion for her. We're gonna actually have her tuck her chin down such that this line, as we drop it down, actually, that's the outer canthus. Close your eyes for me if you would. The outer canthus is there to that ear hole. So when we drop it to the ear hole, watch what happens. There's the ear hole. Now we need to bring her eyes down to that, right there.
So we're matching it.
That is the OML line.
OML. And this is the AP
Correct.
goal.
Correct.
Goal.
Down, yeah, make the center ray come to that goal. We're gonna open it up slightly so we get the top of the calvarium and cone it on the side a little bit. Because we really want the top of the skull. Try to center it. Yep. And I don't care if it's a right or mark. This would be a right mark because she's making.
Yeah.
Thank you for that, Mr. Monk. There you are. So that's the general AP. The PA would be the same, except we would reverse it. We'd exit the Nasion, perpendicular B, using the OML line.
Can you show us them again?
The
They're kind of
which?
confusing. Can you show us them again? The PA?
Yeah, I'm going to.
Okay.
Yeah. So from here, let's continue with the AP, 15 degrees. Angulation, 15 is.
105.
Oops, no, we need to go the other direction. 60
Oh,
is.
60.
60 would be 30. That's 15 from 90. 75?
Oh,
Yeah.
Thank you.
That's a much more clear.
I can get this. There we go. Same thing, we're gonna exit the same place.
Okay. So 75 degree. This is the. What view is this? The
This is
apiaxial?
Caldwell.
Caldwell. Okay.
We're gonna have her tuck her chin down so the orbital medial line is there. This outer canthus and
That's too
there.
much.
We're going to exit the Nasion. Drop the center ray down.
Figure it out from back here.
Are we using more Nasion or here?
In Nasion, this
Okay,
exits
okay,
the
this is
Nasion.
Nasion. So this is, okay. I'm gonna have a.
For the other AP projection, we're gonna do the Caldwell, which is 30 degrees down. This tape is a pain in the ass. Sit in your ass.
Yeah, because I wrote up here and I always
No one?
I thought, a struggle lesson. Yeah, that's what I said.
I guess I should have played the two.
So that wasn't the
That's a Caldwell.
And you're doing another Caldwell?
No, I'm doing an AP Towns now.
Towns. Okay. So Towns is 30. Caldwell is 15.
That detention.
There you go.
That should be it right there.
There we go.
But it's not. It's pretty nice.
shows on the table.
Right?
Okay, it's still go right here if you see it.
Could you step away from that? I'm struggling with this piece of equipment for some reason.
It is, but it
But it's
doesn't
not a green light.
have the.
It hasn't ever matched up
Yeah.
for a
Oh,
long.
okay, thank you. Now I understand.
But it would make more sense for you.
If it did, back this way again. We're using the OML line again, but this time we're gonna come above the gabella. The gabella's between the eyeballs.
Oh, that's the one you're
There.
talking about. Okay, so is it 1 inch above her?
2
Inches
inches.
2
above
inches
the
above the
glabella.
glabella. Okay.
Should be able to get higher with
All
this
right.
tube.
Yeah.
Can't get higher.
Oh, that's it? Okay. This is the max then.
She needs to tuck her chin, so the OML line is actually produced on it. When she touches that, it'll actually make it go up to the level I need. Here we go. Hold your chin like that. I know it's hard. And you'll notice the light will actually transfer across the orbit. Can you not?
That.
So
for mid-sagittally, just
For
like
this
that. Chin
one-
down, don't lift your chin.
you want the infra-orbital matching up with the EAM.
This is an orbital meatal line. The only time infraorbital is for the
This one?
lateral and the SMB.
Okay. Lateral and SMB.
There we go. Good job, relax. A PA would just be the reverse of it. We can do,
So on the practical, is it gonna say whether you want a PA or AP?
no, I'm gonna fool you. Why wouldn't I tell you which way you're gonna do it? Go ahead and check your chin down. So that she uses orbital meatal line. Use the orbital meatal line. Yeah, the outer canthus and the ear hole.
It's just a message.
Yeah, no, it's just like you got the ice rather than
And now we're exiting the nasion. This is just the PA. Oh, and that line. Okay? Perfect. Yeah, the lateral. Yeah, so she needs to oblique her body and then get her face
So this, Mr. Hollister,
as close as she can get to it. This is the infraorbital meatal line.
so that one was a regular PA, not a Towns.
Correct.
Okay. And the
Towns
Towns
is always projection AP, 30 degrees,
so there's,
OML line.
okay, it's only AP. Okay.
For the lateral, the body 70 degrees.
That's a great idea, actually, in terms of, really what we're doing is just obliquing the patient, because the patient can't get in a lateral for our skull, so we oblique them so they can get as close to the image receptor as possible. That's why we're obliquing instead of just putting them in true lateral. Magnification isn't a big deal on it, because we want to be able to see that, but getting the body part as close to the image receptor as possible is really it. So you're right, you're at the base of the skull and the EAM. We're just saying to make sure she's mid-sagittally set up, right? So what we don't want the patient to do is tilt her chin left or right to step off the mid-sagittal plane. She just sees her drop her face alive. See that?
Okay, oh, I got it.
Now what happens is we're gonna go 2 inches. Bring
Wait,
the about 2
can you
inches.
go back to that one? I wanted, Mr. Hollister, I wanted a picture of the other one you just did.
Come this way first, we'll do this, we'll get this done actually. So we're gonna actually go here, move her forward, at the ear,
I don't think he
come
was done
straight
with
up,
it yet. I
2
think
inches
it's
above
like, you
that
have to
hole.
go to that line first.
And
then
then
put
2
it
inches
up
above
2
that
Make sure she is mid-sagittally set up. So that's
Yeah, I
a
think
lateral.
we're still-
So this is a lateral. Hang on a second. And then I'll go back to what we were asking about, LaToya.
She wants a
So
picture
you
of it.
find that, and then you go 2 inches above, and then
The
it's
easiest
lateral.
way to do it, you're absolutely right.
Okay, so you find the hole and just,
Okay.
So this is a lateral for the calvarium. So this is just the skull. By the time we move to the facial bones, we're gonna stay on the maxillary bone actually. So we're gonna drop it off the 2 inches right there about the infraorbital meatal line. And that's actually gonna do well for the facial. We're gonna actually move the patient slightly backwards for the sinuses because we're interested in the front of the face. So this is just the skull.
Would you want to open it up wider?
No, I just want the top of her head. I've got it way too open, by the way. The skull is only this part of the body. The rest of the mandible and everything else is facial bones or sinuses. So this is skull.
So you wouldn't want the whole
Gotcha.
facial.
I don't want the mandible. I could calm it down to here for you, Garrett, if I wanted to. Cool. So that's that. You wanted to see the PA Caldwell? Or AP?
No.
No.
There, I think there was just confusion on the lateral because you have to get him.
You're
You
doing
said-
like 3 different things for the lateral, and that's what's confusing me.
I'm trying to actually show you, go ahead and tuck your chin down again for me, that if we bring the central ray, is, go ahead and bring the light down. Turn the red light on. to the bottom of the ear hole. Go ahead and do that for me.
Yeah, 1 inch.
Sorry.
Keep coming down. It's okay, you're doing great. And I set it up such that the infraorbital meatal line is set up. Then I can come straight up 2 inches. I have a skull, a lateral skull. For some people, they need to see this, then they come up 2 inches. That's what I'm showing you. Come straight up to the ear. 2 inches above the EAM makes for a lateral skull. I think that's probably where the confusion is.
So it wouldn't be simple.
I'm trying to demonstrate
We bring it down here and.
the infraorbital meatal line, and the lateral view is why I'm bringing it down first.
So we're gonna be oblique, and then I'm gonna.
If you can figure it out without the red line, which later on you will be able to, that'll be great. But in the beginning, maybe it'll be easier to bring the line there, then reposition the central ray. Mo figured it out, but it's just one more thing, and we're learning a new process of it.
You said the
Relax.
bottom, so it would need to be like right here.
This is the external acoustic meatus. This is the hole that we use for most of our projections in all skull, facial work, and sinuses work.
So from
Three
there,
fingers for me.
Switch roles again.
I feel like it wouldn't be that
We're
high.
going to do it repeatedly until you get a better idea of it. You're just starting to see it.
It's right here,
And it would be
maybe.
helpful if I did the right projection.
Alright, so this one we're not doing the SMB.
Not yet, because I want to get the first piece of it.
So that was
S&D
everything.
will be universally true for sinuses, facial bones, and skull work.
SMB, the one that's.
Yeah, a person does a backflip. It gets a little more complicated, other than it's the same view repeated. So it bodes to get these first skull work actually figured out. Cool. So an AP projection of the skull involves setting it up such that we are at the nasion with the OML line. And with Yodi, it involves tucking your chin quite a bit. So, that's all right.
Yeah,
Outer canthus to that ear hole is where we are with it.
yeah, like right in the middle, guy.
And we're just going to meet right in the middle of her nasion, between the eyes.
Yeah.
I'm going to move her around slightly so that she's at the mid-sagittal. I don't want her turning left or right with her face. I want her right down the middle of it. Just change the image receptor such that it is
It has to be left or it has to be right.
So what did you there? Yeah.
yes, but she needs to tuck her chin slightly down. There, that?
You'll know.
Come over here.
We should put the correct mark on the correct side.
Yeah, that's
Keep her chin down.
Because then when I did
Outer canthus, it's okay. It's going straight through her ear hole. This is the infraorbital. That's the orbital meatal. Infraorbital,
Yeah.
orbital meatal.
So if we're a little off on this,
That's
If
how you
they-
fail a practical.
Yeah, because they're like this.
That's why we're spending so much time trying to talk about the difference between 7 degrees between orbital meatal and infraorbital. The mistake you will make on this exam is you won't pay attention to the detail. You'll be just sloppy tech who basically doesn't give a shit where you put the central ray. There's a difference between wing and secondary. There's a difference between the infraorbital and the orbital meatal, and I keep saying it's 7 degrees. You need to know the difference between two of them. If we could just put the patient up there and not give a shit about it, then it would be really great. But it turns out for doing proper skull work, facial work, sinuses, we have to pay attention to those details. The thing you're gonna find out, I know this is really hard, the thing you're gonna find out is your patient has to hold the position. And we've all learned that throughout the whole process, right? I mean, we just went through a practical, and we worked together, we remember like, don't you move out of that position. It's the same thing happening right here. I'll give you a story. The horror story of this is, before I actually gave you an opportunity to meet each other and make a decision who I'm going to work with, I used to combine you separately, kind of mix it up. Some of you are assholes, it turns out. I had a student who chose to undermine the other student for their final practical. How easy does it come out of the position? Yogi can tell you, and Ruby can tell you that it's hard to hold the position. So you could easily leave the position and undermine somebody's positioning. Keep that in mind as you work with it. Yes, I know it's hard to tuck your chin down, but you're doing it mutually with your friend. Right? Of course, I have repercussions for people who fuck with other people, but I don't really like to keep that up. So I've left you with your friend. So when you talk to your friend, let them know, again, as I say, where they live, you know, and that they have an animal, you'll kill it first before you go to the children. Seriously, right?
So in terms of
He has a
like,
child though, you can actually take one of his children and leave one of the fingers behind. So this is the struggle in terms of it. The thing that we know about imaging is that when we tell patients to do things, they will do what we ask. It's when other people become more sloppy, like we're like, I'm your friend, I'm busy talking to you, I don't really care. Given the skull work, facial bones, and the sinuses, you have to hold the position for the patient.
so the difference.
You will get good at it the more you practice at it. There is a 7-degree difference. It's a test question, it's a quiz question. It's the difference between a good image and a bad image, repeating the image. So that answers that piece of it for you. You could do it though, because all you have to do is focus on that and let the other person know they need to focus on holding the position. You guys are finished, you can watch somebody else
Oh,
do it
okay.
now. Yeah. Who would like to try it? Would you like to try it now, or you want to watch somebody